hospitals and other healthcare stakeholders are still struggling to understand what data they have and how they can harness it. Can you help us understand the most significant challenges and the solutions that are enabled by technology?
So what's interesting is I spend all day talking to providers, to payers, to life sciences groups about how best they can manage their data, how they can do things like predict readmissions, understand infections, looking at ICU monitors and understanding infections earlier. And we think of all these great things that people could do once they get their data together. But what we see is actually hospitals are earlier on in what we call the maturity scale. So we did a survey a while back, and ever since then I keep reality testing and trying to understand where hospitals are in a maturity curve for analytics. And at one end you have them dealing with Excel spreadsheets and Access databases, and their data is running wild across the organization. And then the next step is they start putting it all together. Maybe they get an EMR, maybe they start getting a data warehouse, they put their data in one place. And then the next level, they start realizing they can pull in data from other parts of their organization. And then finally, at the far end, they get really advanced, they start doing the predictive stuff. And we like to talk about the predictive stuff, but where we find out where most of the hospitals are is just trying to answer the questions they're required to answer by the government and getting to that starting line. It feels like everybody's still getting to the starting line to deal with data. And so I think there's a lot of opportunities there once they get that data in place, but we need to get the tools in place. And we talk about big data, so this is the big data panel, right? Mm-hmm. And the thing with big data is that it is a buzzword, and we focus very much on the attributes of the data. But for me, it's more of a conceptual change and a change in the tools that we have, in that how it's transforming the way people are looking at data. They're saying, oh, see, it's not just the simple data that we have, but what are all the data sets that we can deal with, right? And not all your data is in your EMR. So for one, people like to throw the data in the EMR, but there's more data. There's the financial data, of course, but there's also patient-reported data, like how they're feeling. There's prescription data to understand how they're doing outside the hospital. And how we mix and mash that data to get insights is, I think, a great opportunity. But once again, we're still at that first stage to get to the starting line.
And so in terms of, if I can ask you, Martin, about that starting line, can you, from the perspective of hospital provider side, can you talk about where the Cleveland Clinic is on that starting line, and what you see not just within your organization, but sort of your other peers or other parts of the healthcare
So
landscape?
I think as a practical model, we like to think about it as this data aggregation period, and we've done a lot of work and have done some innovative projects. We worked with Google Health and with HealthVault and have been aggregating data from many sources. So we have payer data today. We have the data that's generated from our EMR. We have the financial data that we send out and the financial data that we get back from payers. And we've been aggregating for a while now. The second phase for me for analytics then is really around transparency. So taking all of that data and making it available in a structured form that allows a physician to understand how they are doing. And so we've been doing that model. We employ all of our physicians, and they all have one-year contracts. And as part of that contract annual performance review, we review their clinical performance on an outcomes basis. So that's now been well established. Every physician gets to see their own score, and they get to see how they're performing against their colleagues over time. So we're pretty well set in that phase. Now we're moving on to what I call operational analytics. So operational analytics, by definition, requires big data infrastructure. So the goal is to take all of that data and to use it to drive the management of variation and to appropriately minimize the variation in care as we go forward. When you think about managing costs in healthcare, most of the cost improvement that we're going to see over time will come with the management of that variation from physician to physician. In order to do that, though, you must deliver actionable information at the point of care in real time in order to change behavior. going forward. So we are doing a lot of that work, and I'd say that's the sweet spot of where we are. And then we're looking ahead to real predictive analytics, and so we do the basics right now. So for example, I came here from Cleveland today, and it snowed. If I had known that 2 weeks ago, we would have downsized the ORs for today because we get lots of cancellations based on that kind of information. And so again, if you're trying to manage cost, using an OR and not wasting an OR day is probably the most expensive thing that you can do in the hospital setting.
And so Iya, in terms of, again, I like this metaphor of getting to the starting line. Can you talk about what you're seeing from the perspective of a healthcare, big data analytics organization? Can you talk about what you're seeing if you look beyond some of the, perhaps the most exceptional examples? You know, Cleveland Clinic may fall into that category. Can you talk about what you're seeing in a broader sense?
Yeah, so broadly, you know, just kind of a starting point, big data is important, but it's not just about the data. The great thing is we're living in a time now where we can start to map out what's happening in the human body on multiple levels, starting from the micro, which is our genetic, omic, to, you know, more macro measurements, what coming from imaging, mobile health, and our interactions with the health system. But ultimately, to get to value and to get to some of the themes that were touched upon earlier, you know, we want to move from fee for service, pay for value. We're going to have to make sense of that data. So it's going to be about the analytics and our ability to crunch those numbers so that we can make predictions. Not only predict what your disease trajectory is going to be, are you likely to get disease, and when you do get disease, what your diagnosis is, but how to actually intervene, how to actually change that system so that we can improve care, and also even understand the implications that that has on a cost perspective. And so in terms of what I'm seeing, it is early days in terms of getting the infrastructure in place, but we're seeing groups and payers on the pharma side taking advantage of the data they have now. You know, can we mine what's already being collected from the data exhaust, from claims, EMRs, and combine those things to actually start to make predictions about outcomes for patients. So as an example, Aetna's already thinking in that space. And we started working with them sometime last year around aggregating and analyzing their data sets that include combinations of claims, health risks, metabolic screening. And they said, look, can you just take all these different disparate data types, integrate it together, and come up with an algorithm that can predict who's likely to get metabolic syndrome in the future, and what are the drivers of that, so that we can start, if we can have that ability to predict, we can start to then create personalized interventions, because not everybody's metabolic syndrome is driven by the same factors. For you, it might be HDL. For you, it might be waist size. And so if we can predict that, we can match that to the right intervention program. And we actually did do that and found that by now bringing together these disparate data sources, we're actually to come up with algorithms that have very high predictability that can actually be used by the end user. And I think that's the key, is going from the data. In order to make sense of the data, we are going to have to deal with that complexity, and it's going to be a complex algorithm, but then we need to create interfaces that allow a decision maker to use it. So in Aetna's case, they're using these algorithms now to pinpoint who's likely to get metabolic syndrome and even help with you know, designing intervention programs that target individuals and actually, hopefully, eventually change behaviors.
One of the things that when we spoke before this event, one of you, I don't remember which one of you said, everyone has a piece of the data, but no one has all of the data. Can you talk, perhaps you, Charlie, can talk about that. How do you account for that in these analytics? And if we're thinking about the predictive side of things, I mean, what to do?
Yeah, I think that presents a great opportunity for companies like IMS, who's here, where different groups are capturing the data at different stages. So, for example, you know, what CVS is capturing versus what you know, the payers is collecting versus what the hospital has versus what the patient has. Is there an opportunity for some sort of aggregation of all that? Is there an opportunity for bringing that together in a way that makes sense? I mean, you know, you don't always know which data sets go best together. You have to bring it together and experiment it. But everybody has, you know, nobody has the whole set. I mean, an example also is that sometimes you might have a lot of patient data, a lot of different patients, but but you don't have it over longitudinality, or you might have a lot of longitudinality, but not a lot of patient data. So how do you, to quote Tolstoy, all complete data is complete in the same way, but all incomplete data is incomplete in its own way. And those holes, how do you patch up those holes, versus real world data or versus clinical trial data that are designed for different things. So yeah, it's a big issue. We did a survey of barriers of analytics, and of course data is always the top one. And so this question of incomplete data always comes up. But, if I can't, yeah, go ahead. You want?
Yeah, well, I was going to say the data is always going to be incomplete in when we're talking about healthcare. And obviously, we're going to get better and better at collecting better data modalities. But and so that's where the analytics come in, is we can start to deal with that messiness. We can start to deal with that uncertainty, and we're going to have to. And our analytic tools actually have to be able to deal with that. And there's other fields that have done this successfully outside of medicine, whether it's physics or engineering, and you can say that those fields are less messy. But they've come up with solutions that integrate both the data side with the analytics and outputs that they can use, and the feedback loops between them, right? So as we start to use these predictive algorithms to actually change how we deliver care and the types of decisions we make, we're going to be producing more data, and you want that to feed back into the system so that we can start to make better and better predictions.
And I don't think we've seen anything yet, because we're thinking about traditional data sources, and I think what we're going to see very rapidly is that it is collecting data from patients at home and what they actually think, but also collecting data from the home itself. So when you really think about managing patients with asthma, knowing the environmental conditions, the humidity in the home, managed over time, external weather patterns, all of those kinds of changes are going to be extremely important, let alone thinking about that most of the chronic diseases, and if you think about 10 or 12 chronic diseases, asthma, heart failure, and the like, you're probably explaining 60 to 70% of all healthcare expenditure. And most of that data really is data that's going to come from outside of the physician's office, outside of the hospital, and is going to need to be managed over a very long period of time. And it has a lot to tell us about medicine that we do not know today.
And what I think is interesting, if I may, yeah.
Please.
What I've been thinking about lately is that, we talk a lot about the poor quality of data, and I think, and I have stories of people who they say their EMRs. There was somebody in central Massachusetts saying that they had a high rate of leprosy or something like that in central Massachusetts, and it was because a department was marking a field that they knew would not be used in Massachusetts for something else. And I think our attitudes, right now we don't have that strong attitude that this data is valuable. So the people who are collecting and creating the data might not realize that they need to have it good at the start, right when you collect it. And I think as we start getting into this world of being more data-driven, you're going to start pushing back the importance of good data all the way back to the people who are collecting it. And I think, we like to poop on EMRs all the time, but the reality is, we're not using them to the utmost of what they could do as data collectors, and so therefore we don't give them the respect they need to have good data in there. I'm wondering if that might be a part to play in the quality of data.
Yeah, I mean, I think as you start to put together these point-of-care tools that can leverage the data to produce predictions that, or decision tools that, people can use operationally, then I think we'll start to change that. So we have to create that end-to-end solution from data to prediction, to be able to using that, to be able to harnessing what comes out of that in that feedback loop. And the system will self-correct, because people will say, look, I need better data to make this kind of prediction.
Yeah, I bet you your doctors are really good at putting very good data into
the system. That's right. So I think it is the great challenge that, physicians really should be knowledge workers in the 21st century. And I think that data should be entered by the appropriate mechanism. And sometimes that's a machine, and sometimes that's the patient. So let's get the people who are most connected to the data to put that data into the system and fundamentally change the paradigm of who does what in healthcare.
So I'm going to open it now to questions. I see there's a question right here in the front. There's one here. You want to stand up so they can see who needs the microphone?
So while he's waiting for a mic, talking about being knowledge workers, in this survey of top problems in getting analytics in an organization, data was first, but the next 5 were all organizational. Do you have the skills in place? Do you have people who know what to do when you get the results? Do you have a data sharing culture? Do you have a champion? Like obviously you are a champion in your play. Do you have the skills in place? So I think, you know, we like to think of big data being a technological problem, but in the end, it's about interfaces. It's about people being knowledge workers and being able to
Changing
deal with
behaviors.
Can we take this question here, please?
Hi, my name is Raj Ramakrishnan. I'm with RTI International. We're a federal contractor based out of North Carolina. We do a lot of work with CMS, CDC, NIH, and we've done a lot in terms of helping them implement meaningful use stage 1 and now stage 2. My question is really this. A couple of years back, there seemed to have been a lot of promise around the quantified self. That is like what some panelists are mentioning, patients entering data themselves, whether it was through a smartphone app or whatever. But the problem was we got a lot of selection bias. We got a lot of ultramarathoners inputting their fitness stats, but we didn't really get those non-compliant diabetics you know, putting in their calorie counts or exercise data. My question is, how do you get patients to enter this data, maybe even passively, where they're not really recognizing that they're doing it? One of the examples that was given was the humidity in the home, for example, and a patient may not even know to do that who's an asthmatic. So what are some of the ways that you folks have seen where we are collecting data passively, but it is about the patient?
Who wants to take that one?
Yeah, so let me start. So I think one of them is that we have to fundamentally change the medical model that we're in. When you ask a patient to actually sit at home and separate from their normal activities of daily living, begin to enter this data that is driven from a medical perspective, it's very hard to do it. The second thing I'd say is that we have to align all the incentives. So they have to be actively engaged in their own health and health care. So we have to give them tools that allow them to do that. And I think that they should also be able to derive some benefit from behaving in the right way. When you do those things, then I think the proper device that you will be using is not a medical device in their mind, but it really will be something like the phone. But it's aligned to the actual incentives that you're providing for the right behavior, that they can practically see and they get real feedback from it in real time, because that's where they spend their life. It's really in work, at play, at home, and that we have to integrate medicine into that scenario rather than thinking about it as something that happens in a physician's office.
Yeah, so doing something that's in line with what they're already doing is the best way. And so you have companies like Ginger.io, Moves app. These are like passive observers on your phone looking at location and motion. We did a project, we're doing a project in the city of Louisville where Asmopolis, and they're not called Propeller Health, they have an accutator that every time you press your inhaler, it sends a signal to your phone so that you get the time and the location, and then they can map it across the city, because Louisville has a really high rate of asthma and they don't know why. And so, you know, but these things were all passive. They're part of the regular process. But the other thing that's going to be a challenge is, what's the value to the patient, right? What's, you know, have we really been, we know, we're very paternalistic, maternalistic, however you want to put it, that we think this is best for them, but what is it that they really want? And we're all patients here at some level. We all go through the system, so we should ask ourselves, you know, what are those systems that are going to help us collect this data in a much more easy way, and what's the value to us? And that ties into your interface.
Another question.
Absolutely. Yeah, all about design, right? Yeah. So if you can design things that integrate into people's lives.
There's one down here in the front.
Good afternoon. My name is Derek Phillip. I'm actually with the Economist group on the commercial side. I think we're having this great conversation about all of the potential ways we can leverage big data for advances in health and so forth and so on. I'm kind of curious as to if you guys as practitioners are thinking about the potential risks of, you know, once you've quantified exactly who I am, now can there be an employment discrimination when they see I have a non-visible disability, or if, you know, we start allocating resources to people who are more likely to be healthy and, you know, greater contributors to society versus those who, by the numbers, wouldn't necessarily.
So there's a role for everything, and I'd say there's a role for policy as we move forward here, because you're absolutely sure if you're just driven by a pure economic model, you will end up where you're describing. And so I think that we are going to have to set those boundaries and actively manage to them. But one of the ways that we can do that is having that data and knowing what's actually happening. If you don't have it, it's very easy I think, to make yourself feel like you're doing the right thing when you actually are not.
So we are running out of time, but I think we can take one more question.
Hi, Steve Wonker with New Markets Advisors. It's a very US-centric conversation that we're having, and I'm wondering how things differ in more centrally directed systems. In particular, I'm thinking about IBM. You had experience rolling out EMR for Denmark early on. Is it an easier environment to collect big data and make it actionable, or is it just a different sort of challenge?
I think that's a great question, because we were talking about the successes at the Cleveland Clinic and wondering if just saying it's going to be done is a great way to get to a certain point. But I think, when we look at what's happening in, if you want to talk about Denmark, it's probably the same size as Massachusetts, I'm guessing here. But, the same kind of idea of scale, right? The US is the scale of Europe, right? And we can't say that Europe has a great healthcare system across, the vast differences between the Nordic countries or the UK and the islands, or like Italy, right? Vast differences in how they deal with data, how they deal with healthcare. So I think on a smaller scale, that's why some, especially like Finland and Sweden, the way it's all, I used to live in Finland, so the way they have the healthcare systems all digitized there, you go from each clinic and they have all that information there. You do anything and they don't ask you your name, you don't have to fill out a forms, right, because they have it all there. I mean, that's a great way to go, right? That's where we want to be, right? But we're going to have to probably take it at a state level or at a clinic level, and it might be evolutionary. We were talking about whether it's going to be evolutionary or revolutionary. It's probably going to be evolutionary, where it's small systems are going to grow. Like, you look at Kaiser in the West, and there's what Kaiser, there's you guys. And I think that's really what we're learning from looking at, what I learned from looking at Europe.